For the n-Lorem Foundation, N of 1 doesn't mean alone because every patient matters. Hope for nano-rare patients and their families has never been more within reach. Visit n-Lorem.org today to donate and make hope possible. This episode of the n-Lorem Patient Empowerment Program podcast is graciously sponsored by ChemGenes, where advancing science is their purpose and helping people is their passion. Since 1981, ChemGenes has been redefining the boundaries of scientific discovery, development, and commercialization by manufacturing and supplying the broadest range of nucleic acid chemistries available in today's market.
Hello and welcome to the n-Lorem podcast series, the only podcast series focused exclusively on the needs of nano-rare patients and families. I'm Stan Crooke. I'm the founder, chairman, and CEO of n-Lorem and your host for the podcast series. And today, as our special guest, is a person that many of you already know, and I've enjoyed knowing him for quite a while, Brady Huggett, who is the features editor at The Transmitter, a journal focused on neurosciences and neurodegenerative diseases. And Brady, welcome.
It's good to be here, Stan.
And today we're going to reverse roles, and Brady's going to ask me questions, I guess, which he's very good at. And we're going to focus on our colloquium, which is coming up.
Yeah. So there's a couple things I want to ask about. First, just about the progress at n-Lorem, and I honestly have some real questions because I've been following, the progress for the past year, and I listen to this podcast honestly. So I have some things I want to ask about, and then we can turn to the colloquium and sort of talk about, what it's going to look like this year and your hopes for it. And so the first thing I want to ask this year is I want to start with patients, and I want to talk about Susanna and Sloan. Right. So Susanna was an early patient at n-Lorem. She has a mutation in the KIF1A gene. You created an ASO for her. She's been on it for years at this point. Yeah.
Mm-hmm. Yes.
Yeah. And you realize that you had another patient, Sloan. And Sloan also has a mutation in the KIF1A gene. I don't know if it's the same mutation or not, but you realize that you could use this ASO that had been created for Susanna and apply it to Sloan. So I wanted to ask how you were able to understand that was going to be efficacious, that it was going to be safe, all the things that went into making that decision.
Good question. So yes, Susanna is now approaching 3 years of treatment and continuing to demonstrate meaningful benefit. And so that's wonderful. Mm-hmm. And we're so happy for her and her family. And KIF1A is an essential gene. So to make an ASO for Susanna, we have to make what's called an allele selective ASO. And alleles are you have two copies of genes. Each of them is called an allele. I really don't know why. You could say two genes. And so if you have a mutation in one copy of the gene, all the cells in your body are mosaics. They have one good gene, one bad gene. They make copies from both. So you have bad mutant RNA, you have normal RNA, and you have mutant protein and normal protein. And we have to preserve the normal. So the way we do that is we do whole genome sequencing. So we can look at the entire gene. And that allows us to identify silent single nucleotide mutations. Mm-hmm. All of us have somewhere around 200-300 million of these silent mutations. And we find those, and then we ask by phasing which gene those mutations are on. We want to know that because we only want to affect the RNA from the one bad gene.
Yep.
And then we design ASOs to each of those sites. So we're no longer worried about the nature of the pathogenic mutation. We're trying to find a way to selectively reduce the mutant RNA and mutant protein. And so we go to that, and most of the time, there are multiple of these silent single nucleotide mutations. And we can use them to identify then ASOs that will selectively cause loss of the bad RNA. And that takes some work, and we're learning how to do it better and better. And I would say we're the only organization in the world that has any real experience with that.
Mm-hmm.
When we get a new patient with the same type of mutation in the same gene, what we do is we undergo whole genome sequencing and phasing again to ask what are the silent mutations that this patient has. On occasion, a second patient or a third or a fourth will have not only a pathogenic mutation that is basically the same, that produces the same effect, but silent mutations that are the same.
Mm.
In the case of Sloan, very fortunately, she had the same silent single nucleotide mutation that we designed Susanna's ASO for, so we could use the same ASO.
I see.
And that saves time and money. And we know it's going to be the right ASO because we already have done all the work to prove that in vitro, and we can do the same work in Sloan cells. And then we already know, because we have experience with Susanna, that if we administer it has a likelihood to work and it is safe.
Yeah.
So Susanna is a pioneer patient. All these patients are pioneers. Sloan joins her as a pioneer patient. And now as we get more and more KIF1A patients, we now have 2 patients we've treated with the same ASO, and we have other KIF1A patients that need different allele selective ASOs because they don't happen to have the same silent single nucleotide mutation.
Got it. Okay. So I guess the question becomes is how often, God, it can't be often, but how often might this occur?
We don't know.
You don't know.
It's going to vary depending on the length of the gene. The longer the gene, the more opportunities. It's going to depend on whether there's something that links the pathogenic mutation to the silent non-pathogenic mutation. Sometimes there may be. And this is unexplored genetic territory. No one knows.
Yeah.
And we don't know. We are able to do it more frequently than I expected. And the FDA is now allowing us to file INDs to treat multiple patients.
Mm.
And of course, if it's a standard non-allele selective ASO, then any patient with a toxic mutation can be treated. But even for an allele selective ASO, it's not going to be as rare as I thought that we can use the same ASO just like we did with Sloan and Susanna. I just don't know how often it's going to be.
Does this do anything to the structure of n-Lorem? Meaning that, when it was originally founded, you thought, okay, we're going to get one patient, we're going to make one ASO, give to them for life. And now you have an opportunity to maybe say, we have one patient, we created an ASO, and we may give that to 2 or 3 other patients. So I would assume that might, that's obviously you get more benefit from the investment that you've made. I mean, are you thinking about these things when you think about the structure of n-Lorem going forward?
Thought about it before I founded n-Lorem. Fully expected to do that. And that's why we picked a maximum number of 30, because we felt that that would be something we could afford to do. There is right now no commercial path, although that may change sooner than later. A lot of progress going on there. We always contemplated the possibility that we'd be able to treat more than one patient. And so we built the systems to do exactly that. And we make enough ASO that by and large we can treat several patients for many years, if not life, with the ASO a single batch of ASO. The smallest batch we can make is 10 grams. That's simply it's just not possible under good manufacturing conditions to do less today. And 10 grams typically will last multiple patients at least a decade or more. And in fact, most of the drug we use is in stability testing, which we know these things are stable, but we have to do them.
Yeah.
So always contemplated it. the systems have been built to be scalable and to manage this situation.
This episode of the n-Lorem Patient Empowerment Program podcast is proudly sponsored by Hanjin Biotech. With more than 26 years of experience in the nucleic acid industry, Hanjin is a specialized CDMO and raw material supplier committed to providing high-quality and high-value products and services with the best-in-class lead times.
Join us for the 2025 n-Lorem Nano-rare Patient Colloquium, hosted by Biogen, this October 20th and 21st in Cambridge, Massachusetts. Connect with members of the Nano-rare community as we explore the latest from the foundation, share insights from treated patients, feature expert-led panel discussions, and more. Supporters, physicians, scientists, and patients and their families will come together for 2 inspiring days of learning, connection, and hope. Don't miss it. Register now to attend in person or virtually at n-Lorem.org.
You have a patient named Rakesh Parekh. He's an ALS patient. I saw this on the Today Show, honestly. I think he's in a trial with 9 other patients. This surprised me a little bit because I didn't think of n-Lorem as really doing much in the ALS space. But what can you tell me about that patient, how he found his way to you, and what you're trying to treat there?
We don't think about diseases. In fact, I think that's an archaic way to think about health and disease. I've been arguing for that for decades. It's time to get rid of those. ALS is a definition of a disease that describes a motor loss, progressive loss of motor function. That's all it is. We know that it's comprised of a sporadic component that there are no genetic defects identified for that, and then an array of genetic types of ALS. And this is the way I think almost all of the so-called rare diseases are going to shake out. They will have a relatively common mutation that causes quite a bit, and then an array of other mutations in other genes and different mutations in the same gene that cause the disease in other patients.
Yeah, like to present similarly.
Yeah, and the phenotypes, if you look at the phenotypes and how they vary for the same mutation, it's much greater than they vary in different mutations often. So if you have a definition of a disease that's as crude as these definitions that we use are, these are centuries old archaic definitions of what patients look like when they're sick enough to come to the doctor. They're from a causal perspective, they're meaningless. So we're not interested. We ask, what is the genetic cause of the disease? We treat the genetic cause of the disease. And that is a reason our success rate has been so high, because it's just a heck of a lot better to treat the cause than the symptoms, and to treat the cause with a genetic drug that's addressing the genetic cause. As I said, the FDA is allowing us to treat more patients with each ASO, and it happens that this is a common mutation that is in the ALS patient population. And this patient had progressed as ALS patients do, and certainly needed help. And I think the evidence is pretty clear, as was discussed on the Today Show, that we are stabilizing, at least preventing it from progressing more.
Yeah, that's interesting. I was at a Gordon conference on ALS and neurodegenerative diseases, and one of the speakers had put up a slide just highlighting what ASOs were in development for various gene variants that are tied to ALS. And it was something like, I don't know, 8 to 10 of them were in development by n-Lorem, right? And that did surprise me because, as I said, I'm usually thinking about, children who are coming, but this seemed like through the genome sequencing that you're doing, you're finding these gene variants, and then you're beginning to make an ASO for them, and they are also variants that are tied to ALS. Is that right?
Exactly. But the patients are arriving to us because of very active engagement by ALS physicians. And so the reason we have so many is a combination of the of the power of the technology and our ability to do it, and the energetic efforts of the ALS physician community and patient community, which of course is very well organized. And we're very grateful for the opportunity to do it.
Yeah. So there's something you mentioned on your podcast too that I heard, and you said this more than once. I think you even said it on CNBC, that what you're seeing is sort of changing the way that you think about the central nervous system. It's more plastic than we thought. It's more plastic than medicine thought. And I mean, I'm working on an article now in which a small trial of 3 SMA patients, they're not severe, they're like type 3, I think, or more. They had electrical stimulation applied to their spine. This gave them benefit, and the benefit lasted for not just days, but for weeks. And the PI of that study said, we think that the motor neurons are more plastic than we thought. And this seems like you are, I mean, I'm not sure everybody agrees with his theories on that. I mean, some do, some don't, but I think you are also seeing through your treatment that, it used to be when it dies, it's done in the body, but you're finding that isn't really the case anymore.
No. Let me preface this with, I'm not a pediatrician and I'm not a developmental expert, neurodevelopmental expert, but like most physician scientists, I was taught that if there was a failure to meet a development milestones, it was forever.
Yeah.
That's just wrong. And not just our experience at n-Lorem, but experience in other clinical trials is demonstrating that. How plastic is the CNS? I don't know. And I don't think anyone knows. But the good news is we're seeing patients who have very advanced neurodegenerative diseases and have lost multiple functions for years, regain those functions. And we're seeing patients who are gaining functions they never had. We have an SCN2A patient who is walking independently. We have an ATN1 patient who, for the first time in his life, is putting on his shoes and socks and catching a ball. If you think about the coordination it takes to catch a ball, just to catch a ball, that's an amazing event. So at a more global level, I believe that the next revolution in medicine is underway. And it's time. And it is a revolution in medicine in which we'll focus on what is a healthy phenotype. If you look up health in the dictionary, you'll find it astonishing. It's incredibly poorly defined. One definition is the absence of illness. Something as important as health defined in a negative way. We're beginning to learn what are healthy phenotypes. How do we maintain a healthy phenotype? And from these unique experiments of nature, who are nano-rare patients who have a single variable introduced, which is the key to all science. Introduce a variable that you can control and then ask, which changes their phenotype profoundly from a health to severe disease. By addressing that, we're able to watch how the disease progresses and how the disease regresses in those individual patients. And that, I think, is where the future of medicine should go. We should focus on health. We should try to understand the factors that are used to maintain homeostasis, that is a healthy phenotype. What happens when a variable is introduced that drives phenotypic change toward disease?
Mm-hmm.
If forced to intervene earlier, because we're sequencing human beings all human beings at birth, and intervene in a much more sophisticated way that is focused on the cause, not the symptoms. And in that future, who cares about what the name of the disease is?
Yeah.
Who cares?
Yeah. Yeah.
That's the future.
You're talking about the revolution and the wave of the future of science. And you've said something else a couple times in the past year, that you think science, and I think you mean basic science, is actually not in a good place. We're in a tough place for basic science right now. You've said that you've talked to researchers and they seem anxious. I mean, at the transmitter where I work, we've had researchers write in saying that they think, that the current Trump administration is leading science astray. The funding issues, of course, they're not pleased with the Secretary of Health and Human Services. So I have some thoughts on why you're saying that, but I want to give you a chance to expand on that statement that you feel like science is not in a good place right now.
I'm interested in the Enlightenment, and the Enlightenment was a product of scientific advances. Newton, Bacon, Kepler, and from those extrapolated into social theory and rationalism, empiricism, and of all the different things that we know. And we are really still enjoying the fruits of enlightenment.
Mm-hmm.
And science, science is a scaffold. I like to say I stand on the shoulders of the great scientists and physicians who preceded me, and and so we all do that. So science is a scaffold that becomes more and more powerful as you add layers, because the advances are cumulative, and that's why we're experiencing such revolutionary power, because of centuries of building that powerful engine. But as with anything that is of value and powerful, like the scaffold of science, it's fragile. It's really fragile. And you cannot simply interrupt that progression and expect that the impact of that to be short. It will have profound and lasting impact.
Mm-hmm.
And that's what's happening. And if you ask what made America's science great, how did it differ from other approaches to science? I think the answer is universally agreed that it was investigator-initiated research. Many other countries do a lot of directed research. And the answer to curiosity is that people do better when they follow their own curiosity. They do better work. And there's no central authority smart enough to understand the world. Think of the universe. We don't understand any of it.
Yeah.
So any interruption in science leads to cumulative severe damage. Any approach that biases scientific inquiry in any way, positive or negative or whatever, is detrimental.
Mm.
Any approach that coerces scientists to be interested in something but not the other, or even worse, somehow be judged by what the conclusions they will be willing to draw, is catastrophic to science. And we're going through all that. And so, the loss of funding, the threats of loss of funding, the withdrawal of funding, and then they give it back, and then you don't. These are things you can't do. There's an enormous enterprise built, and people are paid. They have to make a living. What do you do with those people if you suddenly don't have funding, or you might have funding, or you don't have funding, or tomorrow you will, and then today you don't? Of course, everyone is going to stop hiring, and people who are committed to science will leave and do other things. So we're witnessing, for the first time in my memory, an assault on the basic fabric of knowledge. And science is the fount of the basic knowledge. And so I think anyone who witnesses this has significant anxiety. Certainly I do.
Yeah. Yeah. Okay. Well said. All right. I want to actually take some time and talk about the colloquium too, right? So this is coming up. What is there a main thrust for it this year? A main theme?
Oh, yes. We're now in our sixth year. I mean, whoever said it, time really is relative. I guess that was Einstein. But and that the older you get, the faster time moves. Speaking for myself, I know that's true. It's now almost 6 years. And while we haven't been able to keep up with the demand, and I regret that, but we have raised a remarkable amount of funding and we're getting more. What we've accomplished is, I think, best understood in what we've learned. And so this meeting will focus on what we've learned. And, we'll be talking about what we're learning. Well, first of all, that it's doable. That this idea, which was impossible, actually turns out to be possible. That we can make these ASOs and do it repeatedly and safely and have benefit at in a high fraction of patients. That's entirely never heard of before. That a nonprofit model that tries to deliver care equitably can possibly work. And then all the other lessons that we're learning about health and disease. And we'll talk about that. And then we have real experts talking about all that. So that's the theme. Obviously, we're learning a lot about our patients and their families and the plight that they encounter. And so we hope to share all those learnings as well. So it's about learning. Listen, life is about learning. That's to anyone who is actually alive and interested is a lifelong learner. And so n-Lorem is a learning tool. And it's I think of n-Lorem as an exercise of the mind informed by the heart. And we learn in the mind, and we're learning incredible lessons in the heart.
Yeah.
We want to share.
So, as you said, in your 6th year, how many patients have you infused now?
It changes every day. I think the number of applications is somewhere around 390. The number of applications we process is about 325. I think we just filed our 35th IND. We have also filed a Canadian IND that's been, we've had 35 INDs approved. We're treating, I don't know, many more than 30 patients, but I can't keep track of it. And that's growing sort of daily. So whatever number I tell you today will be wrong because tomorrow it's going to change, which is, nearly an order of magnitude more than I thought we'd have by now.
Yeah, exactly. Yeah. So there's something, you and I've talked about this a little bit in the past too. You're a proponent of whole genome sequencing at birth, right? We've talked about this, and it would give such obvious benefits in many ways, not only identifying people at birth who may have trouble later, you could start treating all those things. But I wondered, is that something, and of course, also, Stan, this would get patients to you faster, right? Is this something that n-Lorem is lobbying for or thinking about lobbying for?
I don't know that I know how to lobby, but what I think matters is that we're providing hard data saying that it will generate immediate value that will bring better health to many people, reduced healthcare costs dramatically. And I mean, the benefits of it are so obvious. And of course, as with any step you take, there are pitfalls, but the pitfalls are manageable. I'm sure that there are worries about being labeled this or that. And of course, no parent or patient should be coerced to do anything. It should be voluntary. But the benefits to our healthcare system just in expense control could make healthcare affordable. And if you think about how much money we spend on end-of-life care, and there's no real data about how much a nano-rare patient costs for life.
Yeah.
These are chronic, degenerative, debilitating diseases. And in most of our families, at least one wage earner has stopped working. Well, I mean, that's a catastrophic loss of value.
Yeah.
So it's a multifaceted opportunity for humans to do something that makes sense.
Yeah. Yeah. One of your episodes this year, you focused on Walt Whitman and his poem, I Sing the Body Electric. And I mean, so when I heard that, I sort of immediately sat up and paid attention because it was a different format. And I know that you like poetry, Stan, so maybe that's simply the reason why you did it. But, I think what you're trying to do with this podcast is sometimes relay to people who want or need to know biological information, the way medicine works, the way the body works. And I think that was a way for you to do it, but maybe in a unique way that as you said, maybe allowed the heart in a little bit more. Am I right in assuming that?
Yeah, I do like poetry, and I find poetry. The reason I like poetry is the same reason I like science. It is the most succinct, compelling expression that one can have. I Sang the Body Electric was a unique poem because it reflected the advances of science at that time. And it provided a great basis for me to introduce people to the fact that we're all electrical machines. And how can we be electrical machines? Well, there are biological systems that generate the current and control the current. And here they are. We know all that stuff now. Walt Whitman didn't know that, but he was smart enough to be excited about the edge of science in his time and to write a poem about it. You know, if I were more capable, I'd write poetry about the things I know and do, but I can't. I'm just not that I'm not that eloquent. So I quote people like Whitman um, and a lot of our modern day poets are troubadours. And so at one of the colloquium, I quoted
Springsteen.
Springsteen,
Yeah.
and dream baby, dream.
Yeah.
Uh,
Yeah.
I realized late in my career that really all I have ever done is be a dream merchant, and dreams are the stuff of life.
Yeah. Yeah, for sure. I've just got a couple of things left, Stan. So you mentioned 6 years, you're in your 6 year at n-Lorem. What has been surprising to you? I mean, I assume when you laid it out, you weren't sure exactly how it was going to go, but what has been surprising about the journey?
The scale of the demand, it's overwhelmed us, and it's been wonderful. We've learned a lot more because of it. But we are really having a real challenge in dealing with the accumulated backlog and how to deal with that for people who are in desperate need. So that the amount of benefit that we've delivered, of course, I expected better a better fraction of success than traditional drug discovery.
Mhm.
We stacked the deck in our favor. We're working on genetic diseases with a genetic cause. We're making a genetic medicine, and we're only working in organs that I'm very comfortable working in.
Yeah.
But I never expected 80, 90%. And nor did I ever expect to see how profound the benefits that we're observing are. Nor did I expect to see the recovery of functions lost and the gain of functions never acquired. I mean, this is all complete surprise to me. And I guess the amount of support that we've been able to generate. I'm not a billionaire. And so Roseanne and I have contributed the millions that we can afford, but we've had to raise a lot of money to try to meet the expectations. I'm surprised by the quality of team I've been able to recruit, because we compete with biotech, and we can't offer options and RSUs and all the money and everything else. But the mission has attracted excellent people who are committed.
Yeah, it's powerful.
And I'm surprised at how privileged I feel.
Yeah. That's it, Stan. I really appreciate the conversation. This is great for me. I'll see you October 20th. And I appreciate your time.
As always, Brady, you asked exactly the right hard questions, and you asked them in a good way. And so it's a pleasure, and look forward to seeing you. Thanks.
Yeah, you're welcome. I'll see you then.
n-Lorem is a nonprofit committed to discovering and providing personalized experimental treatments for free for life to patients with genetic diseases that affect 1 to 30 patients worldwide, referred to by n-Lorem as nano-rare. Many of these patients progress and die without ever achieving a diagnosis. This is where n-Lorem comes in. They do the impossible by providing hope, and for those that they can help, free lifetime treatment. For more information about n-Lorem or today's episode, visit n-Lorem.org. Any questions can be sent into podcast@n-Lorem.org. Search n-Lorem on Twitter, Instagram, YouTube, LinkedIn, and Facebook to connect with us. This video is hosted by Dr. Stan Crooke and produced with the help of the following professionals. Thank you for watching.